Ryan Stan here with ACEP Frontline, and today up in Massachusetts. And how do we say it? Worcester?
Worcester.
Worcester. Okay, I got it. Yeah, I do it like my sauce. I'm like Worcestershire. All right, so talking with Dr. Lauren Westafer. She's actually been with us on the show before. Does podcasting as well as loves the really big fan of the pulmonary emboli. But we're talking today a little bit of ACEP now, as well as an article on D-dimer test for thoracic aortic dissection risk. Could this actually be a game changer? So welcome back to the show.
Appreciate it.
All right, so what we're going to do here is we're going to talk about this. I slid a microphone up during her research discussion that we had here at the conference, so I'll slide that in right after our discussion so you can check that out as well. Make sure that we get in Dr. Westafer's load of PE-related content, but also some other things as well. Learn some things, and I love doing that. So give us a little idea on the D-dimer for thoracic aortic dissection.
Yeah, I mean, historically, it's not been a thing. People have thought about it, it can probably help us because if you get a dissection, there should be disruption in clot and clot formation, the D-dimer might be elevated. In 2015, the ACEP Clinical Policy Committee looked at this and they said, no, you can't use it, it's not sensitive enough and definitely not specific enough. And also, by the way, you can't use a clinical decision tool alone, which would be nice, right? Like we've got PERC and Wells, again, to bring it back to PE, but they said no. And a lot of data has happened in this area because, again, dissection, it's tricky. No clinical sign or symptom, as much as we love to be like, oh, their blood pressures are symmetric and they don't really have chest pain, it's back pain, or they've got all their pulses, that's a good thing. None of those are good enough, and so we miss people and we overtest them at the same time because we're not capturing the right people. And so there's been a lot of work in several huge observational studies looking at risk scores and D-dimer, because it'd be nice if we could use both, just like in pulmonary embolism.
All right, so let's dive into it, because I agree. I still remember just a decade now where we're talking about the idea, can the D-dimer be something that kind of pushes us, kind of back and forth. To me, the D-dimer was always one that kind of pushed you towards the diagnosis in terms of scanning more than it was like with PE DVTs, where it's an opportunity to get out of something. So kind of give an idea of where the data is showing we're going with the D-dimer.
So the data very kind of clearly says that you can use a D-dimer in conjunction with a risk stratification score. Because again, if they're really high risk, you're going to miss more when you add in a D-dimer than if you just kind of scan them all. And so the ADD risk score is the most well-studied of all of the risk scoring strategies for thoracic aortic dissection. And it's super easy because it's only 3 questions. Do you have a high-risk sort of historical feature, like abrupt onset ripping, tearing pain, which is usually you have those to even enter in the pathway to am I going to test you for dissection? The second one is you have a genetic predisposing condition. So Marfan syndrome, you have a known thoracic aortic aneurysm, sort of aortic valve disease at baseline, those common sense higher risk features. And then the third is the bad clinical stuff. So you don't have pulses in one of your legs, or the no-brainer type of stuff. And so you get 1 point for each of those. And to be low risk, your score has to be 1 or less. And those are the patients that you can D-dimer.
And so if those, what you're saying there is, if those scores are in place, you get the D-dimer negative, we're going to say dissection is off the table. And what's our sensitivity and specificity on that?
Yeah, so they looked at this in a study of over 1,800 patients. And of those, they were really high-risk patients. So over 10% of them actually had a thoracic aortic dissection or other acute aortic syndrome, which is really, that's a lot of dissections. And the failure rate using the ADD-RS score of 0 or 1 with a negative D-dimer, and it wasn't age-adjusted or probability-adjusted like PE, it was just that standalone 0.5 or 500 nanograms per ml. The failure rate was 0.3% with a 95% confidence interval of 0.1 to 1. And you can't ever hit 0, so pretty good.
That is really good. I mean, I always remember one of my attending physicians, Dr. Young, he's always running down these diagnoses and what if? And, it's and you'd say, what is the acceptable miss rate? And it was 0. Like, well, that's not realities of emergency medicine. You even talked about in your talk today about the scanning of pregnant females with regard to the abnormal overreads, and we see that all the time. Actually, when you said that today, so when you guys listen to the talk a little bit later, listen to the part about the scanning and overdiagnosis of pulmonary emboli in pregnant patients, because it made me think about the number of patients we're doing cultures now for sepsis and false positives in that case. And so
Exactly.
are we getting so sensitive that we're actually finding things that aren't there? We're seeing ghosts. So how is this going to change our practice? Like right now, everybody listening, how do you recommend them pulling this into practice in their community shops?
I mean, it's well validated, and our ACEP clinical policy in 2025, the ACEP clinical policy, so your organization supports the use of an ADD RS score of 0 to 1 with a negative D dimer to exclude dissection.
All right, talking with Dr. Lauren Westafer, and I know you've covered this before. Tell everybody about your podcast and.
Oh, well, it's a sometimes thing. It's
sometimes.
when the kids don't need their hockey or lacrosse coach, when I don't have research to do in those spare moments.
All right, I'm going to jump everybody over to the talk right now because the room we're in is getting set up for lunch, and so it's not we're not getting a flat tire here. It's getting set up for our lunch, and thanks for carving away a couple of minutes here to talk about it. So let's jump right now to Dr. Lauren Westafer with a research update at Massachusetts ACEP.
You're all set. Okay, so I'm going to give you all some literature updates, just sort of what's going on in multiple areas of things that are relevant to your care. I'm going to spoon feed things to you. I'm not going to really break down the studies. There's lots of nuance here, so as much as I say we're going to science now, we're really just spoon feeding you some updates here. So the major disclosure here is read anything that you think is going to change your practice, but also, trust what I have to say. My perspective is always right. Just kidding. All right, COVID-19 used to be a big thing, and we got really excited about it because it was really bad for a long time, really traumatic for a lot of us. But things have really evolved in this world. So initially, we didn't have vaccines, we didn't have antivirals, and there were some studies published that showed that antivirals did reduce mortality and symptoms and all of that. But it turns out that when people are vaccinated, that benefit really goes away. So in 2025, IDSA, oh, by the way, if you see a QR code, I realize they're not that big there, those take you to the primary reference. So in 2025, the Infectious Disease Society of America said, y'all, if you're not high risk and you have mild to moderate COVID, do not give an antiviral because every medication has side effects, right? And so there's no value and lots of side effects. But we're oh, everyone is a little bit high risk, right? You're over 50, which is, I think, still really young as I get closer. What do we do in those cases? And they said, okay, if, you're moderate or high risk, we recommend that you do give it. And there are certain circumstances, say you can't take it because of med interaction, they recommend another antiviral. But the question is, all the data is largely from the pre-vaccination era. You look at the EPIC HR trial, which showed the mortality benefit of 6%. That was an unvaccinated patient. So what do we do now? They combined 2 RCTs into one New England Journal paper, which is kind of difficult to read and kind of an interesting approach, that looked at Paxlovid in high-risk vaccinated patients. So these patients were 55-ish years old, 90% white. They had about 2 days of symptoms, and then they had a variety of comorbidities, but they weren't all transplant patients, the ultra high-risk patients. And they randomized them to Paxlovid or usual care, and this is the panoramic trial, which was pretty big. Over 3,000 patients in this study were randomized. And they wanted to know, okay, non-elective hospital admission, what do you think? Did it work? No. In fact, nobody got hospitalized in this study, which is fantastic, right? Vaccination can save lives. There was no benefit there for non-elective hospital admission. What about death? And this is from the Can Treat COVID trial. Their primary outcome was hospitalization or death, 0.6 to 1.2%. And you might say, oh, that's a big percentage, but it was 2 and 4 patients respectively, which is almost nobody. And so again, showing that COVID-19 in the vaccination era really isn't that high risk for these types of patients. Again, these weren't the ultra high risk patients, but these were sort of you have COPD, you had diabetes, and your older type of patients. And so I think it's really cool that we're at an era where you can study thousands and thousands and thousands of patients and nobody dies of COVID-19. The other thing is that there were ubiquitous side effects. In the panoramic trial, like 96% of people reported side effects of Paxlovid, but they're like non-serious, right? Like GI upset, bellyache, nausea, vomiting, etc. So the antiretrovirals for your mild to moderate COVID-19 are really out in all but like that ultra high risk patient. So we're sort of beyond that now. But you probably already knew that, right? Okay, the treatment for DKA is insulin, great, okay. And we have choices, right? Are y'all IV drip people or sub-Q people? Depends. But like sub-Q can be in, right? We can do sub-Q now, which is great, love that for us. That's not what's practice changing. How many of y'all are giving glargine or basal long-acting insulin right up front when you start that drip? You give them their sub-Q? Yeah, some people, not a lot. You please interact with me here. It's going to be really painful, and I don't mind long, awkward pauses. You're just starting. I love that. So it's a thing. So there's this systematic review and meta-analysis that looked at RCTs. They looked at 8 RCTs, and these are RCTs that are mostly single center and small, but that's what we got because, you know, why would we treat and study common conditions we see in emergency medicine? Unclear. But in these studies, they randomized patients to basal insulin, your long-acting, like 0.15 to 0.3 units per kilo, or no basal insulin. They looked at like how long does it take to resolve DKA? Maybe not the most patient-oriented outcome, but like oftentimes you're in a unit where they bother you for vital signs all the time. You have to get repeat labs. So I could make the argument that maybe it's a little patient-centered. So it reduced your time in DKA by about 4 hours, and that was statistically significant. Reduced length of stay, again, because you're less time in DKA, minus 3.3 days, which is patient-oriented. And there wasn't a trade-off. They didn't see a lot of hypoglycemia, hypokalemia, those adverse effects you might think of. And rebound hyperglycemia, rebound DKA was less common in some of the studies, but not as consistent across them. So in the 2026 ADA standards of care that they released for hospitals, which is not on most ER docs' reading list, they are recommending early basal insulin. So often it's not what we think of right up front, but it's something I know that our hospital is adding in, putting that in the protocols now as we update our sub-Q rollout as well, because it does seem to improve largely operational outcomes, but they can be patient-centered as well. Okay. Now, I'm sure when they invited me to talk, they were hoping I would cover the breadth of ER literature, but I'm going to focus what I know I'm obsessed with, but y'all probably are too. So in EM, we're obsessed with a few key things. Wilderness medicine, but I'm not going to talk about that. Vests, cozy, practical, you don't have to roll up sleeves. Ketamine, right? What can it not do? We're just going to ignore that last RSI trial. We love procedures, yeah? Pigtails, laryngoscopy. We're also really obsessed with PEs, right? Nothing gives us a bigger dopamine hit than being like, you know what? I got that PE, I got it, and they were PERC negative, and you're like, yeah, their oxygen was 30%, and they're hypotensive and in shock, so I wouldn't really PERC them out then. But we do, for some reason, of all the diagnoses, we're not oh, I caught that septic shock, right? Anyways. But there's a lot to cover here, and so I am going to devote most of my time to this also because I happen to be a PE researcher, so it's just what I gravitate towards. But these are huge behemoth guidelines. There are 75 pages of recommendations, so I'm just going to distill down the key ones that I think are really important in emergency medicine. And there's a lot of nuance here, so I am going to talk a little bit about some of these details. Y'all use age-adjusted D-dimer, right? That's not new, but some people are still reticent to use it. But here's the thing. We're often not using it in the really important patients. In the intermediate probability, we're oh, they're low risk, so I'm going to use my D-dimer. but really a Wells of less than or equal to 6, which is really hard to get to. You're talking PE is the most likely diagnosis, active malignancy, and tachycardia. You know what? You can dimer that patient. And those are really the important patients because it may be positive, but that's where the highest yield patient population is. What about in pregnancy? What do we do? Why would we study those patients? It's only a large proportion of the population who's always short of breath. So it took us a really long time to figure out, like, we should actually, enroll pregnant patients in research studies. I didn't do this, so I don't get credit. I don't know why I say we. But the recommendations are now, in this guidance, to use the pregnancy-adapted years algorithm. Y'all familiar with years? Yeah, probability-adjusted D-dimer, love it, because, they're like, it's a little bit high, but not that high, and you didn't really think they had a PE because you found their pneumonia or whatever. So you can use years, the pregnancy-adapted years algorithm in pregnancy, which is really great because you get that D-dimer, and we know the D-dimer does what in pregnancy anyways? It goes up. Also, do y'all know what proportion of patients we CT angio for PE that are pregnant that have a PE? When they've done studies, it's 0 to 3%. So we are doing a large number of very unnecessary CTAs. What's the problem with the unnecessary CTAs? The number one problem, it's not radiation. So 5 to 25% of CTA reads that say there's a PE are false positives. Another radiologist reads them when they've done these blinded studies. The radiologists are blindfolded, but they're allowed to look at them. They're false positive. And that's a really big deal because you get patients started on anticoagulation and the PTSD rates and generally in patients that are diagnosed with PE are quite high. Their quality of life goes down once they get that diagnosis because they are filled with fear. They can't do the stuff that they were going to do anyways, like, am I going to go coach hockey or play hockey if I'm on an anticoagulant? Maybe not. So just encouragement to thoughtfully evaluate these patients. All right, PE, we used to say massive, submassive. Who here uses that terminology? Okay, good. If you do, and you just don't raise your hand, please stop. Because that's 2012 terminology, and it really, we started using it for big clots. They had a massive PE. And we're talking about size, but you can have a saddle PE and have a low risk PE. Does that make sense? I mean, it doesn't, but it does because it's about physiology. So PE is a spectrum, and we've failed to capture this in every risk stratification guide. ESC got close in 2019 with low risk, intermediate, high risk. Sound familiar? Yes? Yes, we were so involved with that. But it still didn't quite capture all of the spectrum. And so we know that there's a population that's no big deal, you can go home, right? You have a PE, often we're oh, it's small, it's fine, but really you just have to have a low risk PE, be hemodynamically stable, no major contraindications to anticoagulation, and you could go home. And these guidelines, again, support, please discharge these patients because, again, we're really bad at that. And then the other end is what? The fun ones to treat, the shock, ECMO, you're gonna do all the things. But then there's that middle ground that's kind of tricky, and that's not new. But what is new is they're giving letters to it to help delineate it a little bit more. So you still have those two categories. The really interesting part is that middle section. The other fun thing is all the other ones were oxygenation and ventilation isn't that important. It was nowhere in the risk stratification when you have a hypoxemic patient or somebody that's on high flow or non-invasive. And so now that's actually included, and you kind of move up the category based on your oxygen requirement, which is fun. That middle category, that C and D, kind of depends on assessment of the RV. Y'all do this, right? You see, do any of your reports say there's RV strain or something like that? So which is better? Do you really need to go find the ultrasound, go get the gel because it's out, and ultrasound their heart? Is CT good? The guidelines recommend use of echo over CT. They couldn't say you need to do the echo because not everywhere has formal echoes, not every hospital medicine clinician can do an echo, et cetera, and it's so easy to just read the CT report versus actually go through those steps. But they do recommend echo over CT, and that is because CT is really sensitive. Really sensitive. This was a study at MGH where they looked at per activations that had CT angio and TTE. And they used TTE as the gold standard because it's a functional assessment of the RV. And they found it's sensitive, but is that a good specificity? This is our sciencing section. No, that's abysmal. That's worse than D-dimer for things, and we love to hate on the D-dimer. So it overcalls RV strain significantly when it's not actually there. And so that's why echo is recommended in these guidelines. So if you have a minute, just go on. TAPSE's not that hard. Look at the squeeze, look for the McConnell if you can, but really, really focus on doing that echo. So that C&D, abnormal RV and or biomarker, that's your intermediate, low, intermediate, high risk patients with a former classification. But the biomarkers, we gotta talk about the biomarkers. Y'all getting tropes and BNPs in these patients? I mean, they got them in triage probably, am I right? Yeah, okay. Because chest pain and shortness of breath. So usually you already have these back anyways. The problem is, we don't know what cutoff to actually use. We know that if you use a high sensitivity trope and not a conventional trope, that you classify a lot more people as higher risk, but they don't actually do worse. They don't have complicated courses. They've done that study, so we don't really know. You gotta have to kind of look at their comorbidities and all of those other things. Unfortunately, they're like, do it, but we're not gonna tell you how to use it. So you gotta kind of use your common sense there about do they have an AKI? Do they have chronic heart failure? Are they always elevated? Anyways. Okay, so this is the spectrum. That category C is you're really focused on your RV, your biomarkers, your echo, all that. Maybe also a little bit of O2, not a lot of O2. The category D is the new one. This is where they're so the patient isn't dying yet, but they may be circling the drain. Your young patient that their blood pressure is pretty good. They probably have undiagnosed hypertension at baseline, but their lactate's 4. Is that bad? Probably. And then that's a patient that gets admitted, boarding in the ED, and then they die. I mean, hopefully not. But so that's your category D patients. Your persistently elevated lactate. So not a single isolated lactate that's high, because your lactate can be 2.2, which is high, and then you repeat it. And if it goes up to 4, that's bad. If it stays the same or goes down, that's good. So they are recommending you get a lactate in those patients. So now not only are you getting a trope of BNP, but maybe a lactate or 2 and then trend it. The problem is, again, we don't know the cutoff. So this was a study that looked at normotensive PERT activations at Vanderbilt that had a lactate drawn. And they were okay, what is the value of those that that died or had an intervention done? 2.1. What do you think of that? That's real close to normal, right? Do y'all know what that plus or minus 1.3 is? The statistical term would be a standard deviation right there, right? So the standard deviation is 1.3, which is enormous. So again, we don't know, could it be a normal lactate or an abnormal lactate, a lactate of 1? And when they looked at, in those that didn't have death or intervention, their lactate was 1.9. So do we know a good lactate cutoff? No, we don't. And when they tried to model it, and they're okay, we're gonna look at all comers, and we're gonna look at intermediate risk patients. These are area under the receiver operating curves, and the closer they are to diagonal, the suckier the test. So on a scale, is this good or not good? Yeah, this cutoff did not perform well in that. So again, get the lactate, but we don't know what to do with it. Trend it and leave it for the inpatient team to do, right? Okay. The treatment for PE is largely class of medications, anticoagulation. Look, I'm only going to ask easy answers here. Okay, anticoagulation. What anticoagulant y'all like? Lovenox? Okay, all right. This is something I made, but they have a table like this. If you read one thing in the guidelines, they have a table that looks really similar to this. I may have almost copied it, but just added some things that also bother me. But it basically tells you what to do. If they are A or B, symptomatic, low severity score, put them on a DOAC and send them home. If they're pretty much any other category, even if they're super duper sick, what are you gonna put them on? Isn't IV heparin stronger, faster, better? No. Yeah, you're triggering me, I know that. Yeah, so there's been this increasing use of IV unfractionated heparin despite 18 randomized controlled trials demonstrating that low molecular weight heparins are associated with reduced mortality and reduced risk of hemorrhage by about 31%. So which one is better? Lovenox, right? So there's this myth that IV heparin is stronger and faster and better, and it's IV, so if our patients are really, really sick, or it's a really big clot, that's what we should do. But again, they lay it out pretty clearly that the only group that you should consider unfractionated heparin in is maybe those patients that are dead or dying. And so I thought that was pretty clear. They also kind of go through like which ones might you consider various other options for. Okay. So again, they gave this a class 1 recommendation, which is the strongest recommendation they can make because there are multiple RCTs. Low molecular weight heparin is recommended over unfractionated heparin. We can all say we do it here, but in practice, oftentimes it's really different. And we did a study in 75% of hospital admissions that received parenteral anticoagulation in the US between 2023 and 2025 got unfractionated heparin. So we have a lot of work to do here. Not only is it worse for patients, this is a study of PTTs. Nurses have to chase the PTTs, right? And if you think really far back, or maybe not so far back, to your MICU rotations or whatever, and they're never in the therapeutic range, right? This was a study done where they looked at the sick patients, and each one of these is a 6-hour block, like from 0 to 48 hours. The green part is the proportion of patients at any time that had a therapeutic value. Is it the green bar, most of them, or not most of them? It's very, very few. It's like less than 1 in 5. Most of them they're subtherapeutic, which is not good, right? Especially for your sick patients with a bad PE, you want them to be anticoagulated, or they're too high and they're at risk of hemorrhage. So again, low molecular weight heparin for most patients if they need a parenteral agent. And you can dose reduce it if they have a high BMI or bad kidney function. Should we intubate or sedate these patients? What's the problem? Positive pressure is really not good for a sick RV, and also you need a little bit of their sympathetic tone to sometimes keep them alive. So intubation and sedation is really high risk in these patients. So before you're like, oh, I'm just going to put them on non-invasive, I'm going to sedate them, and all this stuff, that's really not good for patients. If you do need to tube them, then please sedate them, but just be very careful about what you give and really think about, do they really need that positive pressure? That's a harm recommendation. But you didn't want to hear about anticoagulant, right? That's so 2000s. What do we love to do now? Call the prayer team. Maybe they can suck it out, do something. Lytics, right? That's a fun thing. Because you get immediate resolution, right? Our interventionalists will text us pictures like this, and doesn't it feel good? This was from last week. It's look at all that clot. It's out of them now. They must do so much better. Lytics. Again, very early 2000s, right? The truth is, we don't know the proper lytic dose of PE. Isn't that fascinating? It's what we do for the sickest of the sick patients, and we have no idea. Do you give them full dose, half dose, quarter dose? Do you make it up? Do you give them an infusion? We don't know. There's no good studies on this. And again, no NIH isn't interested in funding it because we have catheters to suck it out. But they do say, hey, low dose is fine. 25, 50 milligrams, they put that range in there of alteplase. The truth is we just don't know. So consider a lower dose if you are going to lyse somebody. In the guidelines, they also have a table that kind of goes through, okay, for each category, what kind of treatment for the fun stuff should they get? Should we lyse them? For categories A, B, and C1, do you think any of those patients should get thrombolytics? Right? None of this is novel. Don't do it. It could be harmful. But then it kind of goes through. So maybe their RV is a little bit sick. Should we do it? And again, they have a table in here that's sort of probably not. And it kind of goes through. So you start, the green is where they say hey, maybe consider it. And that's really your D patient. So the elevated lactate, the transient hypotension, the sicker patients, onto E1 and E2. Refractory cardiogenic shock. Again, the role of ECMO to bridge to surgical thrombectomy, or some of the catheter-directed treatment if they're not quite dead yet. So they have a table. Again, the guidelines have some great things in there that are visual references to help decide some of those things. Not that you're you know what, we put lines and tubes. We do Seldinger for everything. We could do this in the ED. Not that you're making that decision there, but if you're thinking like, do I need to transfer this patient? What are the odds that I should advocate for one of these procedures? Did any of y'all read this trial? It made a lot of news. High pytho. So they make all of these recommendations about like catheter-directed thrombolysis and mechanical thrombectomy because they're super fun and there's a lot of industry interest in using them. But do we have any randomized controlled trials comparing them to anticoagulation? The benefits are like, do they get better if we do it? Not like, or comparing them to each other, not comparing them to the cornerstone of PE treatment, which is anticoagulation, which is kind of funny because that's not the way you should science, but alas. Until now. So one was just released in New England Journal of Medicine a couple weeks ago, high pytho trial, and this used the ecosystem. Any of your hospitals use that? Ultrasound facilitated catheter-directed fibrinolysis. It's the one where they have to go to the ICU because they're putting some lytics like right there, right in the pulmonary artery. Okay, if you read their conclusion, they say it looks good. It led to a lower risk of composite pulmonary embolism-related death, decompensation. That looks good, right? Looks good. Okay, and it's a big trial. 544 patients with this like intermediate risk PE. You had to be tachycardic. You had to have an RV greater than 1.0 compared to the LV. So like more of those intermediate risk patients with former categorization to ECOS versus anticoagulation. What anticoagulation do you think they use? Do you think they use the right one or the wrong one most of the time? Unfractionated heparin. It was 70%. So not like ideal anticoagulation either. Okay. I digress. I'm going to interject with my opinion if you haven't noticed, but it's to make you remember it more. All right, composite outcome, PE-related death, deterioration, 7-day symptomatic recurrence, look good, right? Like that's a huge relative risk reduction, right? Big, 0.39, very statistically significant. The p-value is very, very small, but we don't like p-values. But when you look at like, but did you die? It wasn't death driving that composite outcome, right? But maybe it was symptomatic recurrence. No? What do we think drove that outcome? Cardiorespiratory deterioration or collapse, which also sounds really bad, relative risk reduction of 0.40. That sounds bad, but when you look and you have to like dig through the supplemental appendices, it wasn't driven by signs of shock, placement on echo, intubation, or non-invasive mechanical ventilation, the things that we really care about. It was driven by a news warning score of greater than or equal to 9. I don't know about you, but like my patients are like, my news score was only 5. That's just not like what we do. So it had this great composite outcome that was largely driven by a news score change, not by any patient-oriented benefit. So you might say, but maybe their functional status was better. And when you look at their 6-minute walk test at 30 days, they were, again, we don't do this in the ED, but these are kind of bad at baseline. These aren't like great 6-minute walk tests. But they gained, what, 12 meters? And at 30 days, that's not a significant amount of difference between the groups. So, people are very excited about this. I think the patient-centered benefits here are overstated. I think we need more data. There are randomized trials looking at mechanical thrombectomy too, and so hopefully we'll be able to get a more granular picture about like which patients do benefit. It looks to be probably the younger ones in the like secondary analysis and subgroup analysis that they did, but I think some of the patient-oriented benefits are overstated. Okay. Got like 5 minutes, right? 5 minutes? Okay, we're gonna move on to not PE, which breaks my heart, but not everything is PE. The treatment of vertigo, like think peripheral vertigo. You have a patient with peripheral vertigo, is it a donut of truth? Is it antihistamines like meclizine, or is it the Epley maneuver? What do you think, A, B, or C? No commitment, you just don't treat their vertigo. Admit to medicine for stroke rule out. C, Epley, that is the correct maneuver. Thank you for participating. I appreciate that immensely. Okay, yeah. I would like to say C is definitely the right answer. Is it what we do in clinical practice, or do we order some meclizine and walk away? Yeah. So like, there's what we should do, and then there's what we actually do. Meclizine is an antihistamine, and by the way, there are guidelines that say we should not routinely treat BPPV with vestibular suppressant medications. So guidelines actually recommend against using diphenhydramine. Bless your heart if you're using that, please just don't. Or meclizine for the treatment of vertigo. And you're like, so what do I do? Like, because we don't want to just stand there, we want to do something, right? Like, even things that we know have no value, like IV fluids in routine migraine treatment when you're already treating their migraine with our famous migraine cocktails. We just feel like we have to do something. So this was kind of a fun study because it was like a mechanism of action I never thought about. Sodium bicarbonate for the treatment of vertigo. It's fun because you get to give it IV, and we love doing more invasive things that may or may not have any benefit. But this randomized patients with non-central, like various causes of peripheral vertigo, acute, so under 24 hours, to IV diphenhydramine, which is again a terrible drug, sodium bicarbonate with a little over an amp, or both. Does anyone here know what the purported mechanism of sodium bicarbonate is in vertigo? Inner ear perfusion, increased inner ear perfusion. I have no idea if that is actually the truth. Anyways, that is the purported mechanism. Apparently people have scienced in that area, and believe that's the case. Okay, they wanted to know, like, was your vertigo better in an hour? Which I think is like fairly reasonable, and there's like a vertigo scale, like smiley face or like frowny face and then through. I mean, that's not exactly, but you get the gist. And so diphenhydramine put them to sleep, and so then they slept through their vertigo. The sodium bicarbonate had about the same, and then both you were also sleepy and there. So it did appear to improve the subjective perception of vertigo in those patients. And when they mapped it out over time, dropped it at 30 minutes, it dropped at 60 minutes, and then they had them like rotate their head and like walk, which is like really important, right? Because you gotta always be dispoing, and you gotta be able to walk if you came in walking or can walk at baseline in order to get out of the ED. And so the orange line there is the sodium bicarbonate. You can see it mirrored all of the other ones. They all have sort of overlapping confidence intervals, so that sodium bicarbonate appears to work. Who do you think got lethargic? Again, it does hinder dispo. It's like, I'm a nocturnist, so like at night it's really hard to be like, are you altered and in a coma, or are you sleeping because it's 2 a.m., right? And then you're the mean one that wakes them up and then they get delirious. Anyways, it's a hard job. Okay, but obviously there was no lethargy or less lethargy in the sodium bicarbonate group. There was most patients in the diphenhydramine groups had lethargy, which is something I prefer not. Sometimes people are like, with migraines, like, but you want them to sleep, and I'm like, I want to move patients through my emergency department. Anyways, I think that, like, for me, I've done this a time or two. IV sodium bicarb. If they have a line and you're feeling like you want to try it, sure. Like, there's as good evidence as there is for anything else, because meclizine has like minimal data besides a 1968 study where they put 16 patients in a little centrifuge thing for fun. And there's a vomiting score that they use. Anyways, fascinating what people do. Okay, anyways, so it might be worth a try if you're out there and you want to help a patient and they got a line. Better than diphenhydramine at least. Okay, I am going to call it quits there on the literature. Thank you so much. And just please read those papers yourself, especially the PE ones.
Dr. Lauren Westafer with a research update as well as our discussion on the D-dimer's role in thoracic aortic dissection, putting a rule and a D-dimer together to change your practice. And as for me, contact me, rstanton@acep.org, rstanton@acep.org. I invite you to download the podcast, like it on your favorite player, give us 5 stars, push us up the list. Until next time, I'm Dr. Ryan Stanton, and this has been some ACEP Frontline.
If you're not on the front lines, you're on the sidelines.
Cue the music.
Bow, bow, bow.
There. Quiet place, all
Yeah.
alone. Da, da, da.